Okay. Dr. Ahmad, are you with us?
Yes, I'm here.
Okay. Hold just 2 minutes.
Okay. Okay, I'm ready for discussion.
Okay, let me adjust 10 minutes for you and start.
Hello, I'm Ahmed, ready for discussion.
Okay, Dr. Ahmad, you have this patient in your clinic. She is a 24 years old with chronic kidney disease and she did renal transplant since 4 years. And she is now in your clinic. She keen to have a baby. So could you tell me what is the important point in the patient history you wanted to know about this patient?
Okay, so after introduction myself to the patient, I'm gonna take a brief history about her kidney problem. I'm gonna ask her, do you mind you tell me about your kidney problem to know more about what is why she had a renal transplant, any complications after this operation, which kind of medications she's following on, which kind of doctor she's following with, and if she's in a stable condition or not, if any recent flare or any problem with her kidney functions, and about her last visit to her doctor. I need to ask her about if she informed her doctor that she's wanted to get pregnant. So what's his recommendation about that? I need to ask her about any history of diabetes, because it could be diabetic nephropathy cause that problem. About her current medication, if she's got any swelling, any shortness of breath, any vomiting, any confusion, any difference of color of urine and amount of urine. I need to ask her about her obstetric history, if she got any pregnancy before, and if she got pregnant, how about if any complications, what is the root of previous pregnancies, it is before the transplant or not. I need to ask her about gynae history as well, just to check about her periods, if she's regular or not. Um, any up-to-date smears, any discharge, and any kind of contraception before. I need to ask her about any other medical history, if she got any other medical history like diabetes, controlled or not, any surgeries as well, just to make sure that it's okay for her. I need to ask her about her medication, she's taking folic acid or not, what is the dose of folic acid, any allergies as well. I need to ask her BMI and rhesus factor. I need to ask her about her family history, and family history of inheritance. It could be inheritable disease, any social history, smoking, drinking, recreational drug. I need to ask her about her psychological history, mental history, if she got any depression or not. This is most what I ask for.
Okay, Dr.
Yeah.
Ahmad, this is the history of the patient. So can you have a quick read, please?
Yes. Yes.
Okay, so how you will manage this patient in the preconception period, in the antenatal and the postnatal period as well?
Okay, so preconceptional period, I'm gonna refer to just to liaise and discuss with her kidney doctor about her kidney condition, about suitability of getting pregnant at this time, because she's taking mycophenolate and tacrolimus linzoberine. I'm gonna discuss with her kidney doctor suitability to stop this medication or to shift this medication to more safe with pregnancy. I'm going to discuss with my consultant as well about this issue. I need to start her on folic acid if she's not on folic acid, and aspirin once getting a pregnancy. Once getting the pregnancy, I need to to arrange a follow up with a kidney doctor just to check about her blood kidney function. I can see here as a creatinine is a little bit elevated, and we need to arrange about some scans to check her tummy and uterus. She's taking Cerazette at the moment, which is considered many bells reliable contraception. I need to continue until we decide to stop it to get pregnant. This is about pre-conception counseling. As regards getting pregnant, after getting pregnant, her care will be under multiple of doctors. So it will be under consultant, obstetrician, local transplant team, and a nephrologist, endocrinologist as well, a specialist midwife. During the first trimester, she will be it will be frequent visits, so we need to take her booking bloods to make sure kidney functions and to rule out any viral infection, and just booking screening. So we need to assess her for a VTE assessment from the start of pregnancy. She may start blood thinning medication, low molecular weight heparin, especially if she got high proteinuria. We need to check her renal function monthly, and send MSU as well to check about proteinuria. On the second trimester, we need to check about fetal anomaly scan and 20-week scan and serious growth scan, especially during the third trimester, to check about baby's growth. We may offer her, if she doesn't give her any history of diabetes, oral OGTT test at 24 weeks to check about diabetes. We need to, at the end of pregnancy, around 36, we need anesthetist to review her just to put a plan for delivery as well. We need, in pregnancy, we need to start her, like I said, on aspirin to avoid risk of preeclampsia, to start her on low molecular weight heparin if she score high for VTE. And
Okay.
yes.
Delivery wise.
Yeah, on delivery wise, she should be on consultant lead unit. As regard the time, it will be after maturity, after 37 weeks. We may go to up to 39 weeks without any concern. She will be for vaginal delivery, except if any obstetric causes only. She will go for a C-section. As regard the precaution during delivery, it will be, if she is on IV hydrocortisone, we're gonna give high dose of corticosteroid. If she is high dose of 50 to 100 milligram every 8 hours. As regard the monitoring for the baby, it will be continuously fetal monitoring, and for the mother, it will be just measuring fluid balance during labor. Keeps the patient hydrated without volume overload as well. This we can offer her induction of labor if she went to 40 weeks without any labor pain, but we will try to progesterone is prostaglandin is okay. It's considered safe. It's according to her her bishop score, but I have some concern about prostaglandin E2. I'll double check with my consultant if it is safe to be given at this point or not.
Okay, in case of cesarean section, any precaution for this patient?
Yes, in C-section, because there is a risk of trauma for the ectopic or implanted in kidney 1 to 2%. It will be midline skin incision. It will be under in consultative care in presence of consultant and the transplant team as well. We sometimes when we offer her a scan before the section just to locate where is the renal graft. It will be like a consultant. It will be midline skin incision. Then the uterus in itself, it will be transverse lower incision. Try to avoid any problem. And during a C-section as well, we will give her high dose of steroids.
Okay, postnatal.
Postnatal, we will try to actively manage the third stage of labor to try to avoid ergometry because it's not suitable with high blood pressure or kidney patients. As regard the breastfeeding, we will encourage breastfeeding and we will ask the baby doctor to review the baby. We'll assess her for VTA assessment to give her thrombophilaxis for around 6 weeks after delivery. We'll provide her with proper kind of contraception to avoid unplanned pregnancy later, and we'll arrange a follow-up with a nephrology team as well. For the baby, if she's taking specific some drugs which is decrease the immunity, sometimes we offer to decrease avoid live attenuated vaccines for the baby. As regard to breastfeeding, for if she's taking sometimes there is some side effects from some medications. We will try to liaise with baby doctor about these issues.
Okay, thank you, Dr. Ahmed.
Okay, thank you. Thank you.
Brilliant, Ahmed. Thank you very much. You did the task in very, very nice. Okay, excellent. To be honest, everything is you tackle the point, all the point regarding all the question. You answer all the question in very good way. Your applied knowledge about the transplant organ and the management of the pregnancy transplanted kidney is very good. So I didn't think you missed any point. Very, very small point, like to warn a patient to monitor the symptom and sign of acute rejection of the kidney. Okay, so if she feel fever, line pain, anuria, or any deterioration of her kidney function, to check or to come immediately to the hospital or to refer herself back to the specialist doctor. Okay, and you talk about the steroid. If she is on IV hydrocortisone, she should be given hydrocortisone. I think you mentioned the dose in not correct way, but if it in prednisolone tablet, even if it tablet not necessary to be on IV, even if it and prednisolone tablet 7.5 for 2 weeks, she should receive the stress dose of hydrocortisone, which it will be 100 milligram every 6 hours till the delivery. This is a very small point, but otherwise your answer, your performance is excellent in all the question from the first one to the last one. So the first question, what is the important information you wanted to know about the patient? You go systematic and organized. You ask about everything. The most important is the history of present illness. We have a template already in our mind. So even if the structured discussion, we should have a template in our mind, like in the simulated patient task. So how the history should be started? It should be started by the history present illness, then go to obstetric if we are going to talk about obstetric patient, then gynae, the medical, surgical, and social, drug, family. Okay, and this should be the organized. So you should have a template in your mind, like Ahmed did. Okay, start usually by the history present illness. So it can't be in the exam to start by, I will say, I ask about her, for example, smoking, or for example, her social life, the support at home. You cannot start by this way. You can start to ask about the kidney disease. Okay, what is the main problem? The kidney disease, which is the history of the present illness or analysis of the complaint. You may say, Ahmed, also I will review the notes of the patient. So collecting the information can be done from the patient history and also from reviewing the patient's notes. So history present illness, you ask in details about everything. Thank you very much. You ask about the kidney disease, okay, and the renal transplant, any complication have happened after the transplant? When was the last consultation with her kidney doctor? Did she talk about her plan with the specialist doctor? She mentioned that she talked about her intention to be pregnant with her specialist doctor and what he advised her. He may be advised her not to become pregnant. Okay, so we have to know that. So did she talk about that with her specialist doctor and any recommendation for him? Okay, and what is the blood test? What is the last kidney function test and how she feel right now? Then go to the gynae history, ask about the period. Okay, she may be pregnant now, so I want to ask about the period and last one. And we should ask about the contraception. She may not use contraception, and we wanted to postpone the pregnancy now. We wanted to give her another one. So, like Ahmad mentioned, what is the contraception she used? Okay, any medical background, it may be the original cause or it may be the problem of the kidney disease like hypertension or diabetes. Whether she had any surgeries before, it may affect our mood after that of the delivery. What the drug she used right now for this, what is the drug, and whether she started to use folic acid already because she is planning to get pregnant. If she has any allergies at all, okay, then the social history and the family history if relevant. Okay, so the examiner will give you a piece of paper by this like that. Okay, you may read this information by silent way, in silence. Okay, if you don't want to read it by loud voice, or you can read it in front of the examiner, but don't read it as it written for you like that. Don't read it like it is written. Try to make a summary for that. Try to make a summary for the notes for the examiner, or you can read in your silent and don't make a loud voice. So the examiner will ask you after that what will be the management plan for you for this patient in the preconception and the antenatal and the postnatal period. In the preconception period, if any patient with medical disorder come to talk with you about her plan for pregnancy, or about her intention for pregnancy, you have to talk about two things. Two things is very important in the preconception period. To talk about the drugs, to review the drugs, and to talk with her about the effect of the pregnancy and on the disease and the effect of the disease on pregnancy. I think Ahmad missed this point. To talk with the patient because she may not know about the effect of the pregnancy on the renal transplant and the effect of the renal transplant and the kidney disease on the pregnancy. You have to talk about this as well. So regarding to review the medication before pregnancy, Ahmad did it in a very nice way. This patient she already on mycophenolate, so she should stop this mycophenolate at least 3 months to give time for wash up, and she should use another regime for that, like azathioprine. She should continue for the contraception till the time of the wash up of the mycophenolate and stabilize on the new regime, and should you continue the folic acid for at least 3 months before conception. This is regarding to the mycophenolate. Go to the lisinopril, as Ahmed mentioned. Also, she has to change this to a baby-friendly drug. You may mention what should be the baby-friendly drug. It may be labetalol or alpha-methyldopa. The tacrolimus also need to be adjusted, or the dose need to be monitored every month during pregnancy, because as you know, the level of the tacrolimus can be decreased during pregnancy. Then go to talk about the effect of the disease on pregnancy and the effect of the pregnancy on the disease. How could the renal transplant affect the pregnancy? Yes, her baby may be grow smaller than expected preterm. You can mention preterm because we are in structured discussion. Okay, no problem to use jargon or medical terms. So the patient may have a preterm delivery, may have a small for gestation age, stillbirth, congenital anomaly, and the mother herself may have preeclampsia and gestational diabetes, and she is at increased risk to have cesarean section. Regarding to the effect of the pregnancy on the renal graft, they may happen deterioration of the kidney function and acute rejection as well, which is in 2% of the patient. So the care of the patient, the antenatal care, how could be done? The antenatal care, Ahmad mentioned it in a very nice way, very, very, very good. He didn't miss any point. Multidisciplinary team, including that and that and that. Consultant lead unit. Okay, she will be offered the routine booking test as any other woman. Besides that, we will add a renal function test and the 24-hour proteinuria and MSU. She will be offered the dating scan, the anomaly scan, growth scan. This patient should be offered the growth scan. She will be offered low molecular weight heparin, especially if she has significant proteinuria, like Ahmad mentioned. She will need tacrolimus to be monitored every month because its level may be affected by the pregnancy. Her blood pressure should be monitored and should be kept within the normal range, and she will need the multidisciplinary to adjust the mood and decide the mode of delivery at around 30 to 34 weeks. So how will be the delivery of this patient? The vaginal delivery is recommended for this patient. The examiner may ask you about that. Okay, whether you recommend for his cesarean section? Cesarean section only if obstetric indicated. Okay, so vaginal delivery is recommended for this patient, but during the vaginal delivery, we have applied for her continuous monitoring. If she is in prednisolone, she should receive the stress dose of the hydrocortisone, avoid ergometrin in case of hypertension, and the prostaglandin and oxytocin, like Ahmad mentioned, no problem for this at all. In case of C-section, okay, so the multidisciplinary team should be included because they know the site of the graft. She can be offered ultrasound before the section. We will do midline skin incision and transverse uterine incision. There is risk of uterine trauma about 1 to 2%. Postpartum, the baby doctor should examine the baby. Okay, some baby may have thymic hypoplasia from the steroid. We will keep the blood pressure within normal range. Should be referred back to the transplanted team. She can refer back. She can come back to the enalapril if it's necessary for her to come for ACE inhibitor. So enalapril is safe for breastfeeding. Contraception, like progesterone only contraception, will be safe for this one. And monitor the symptom and sign of acute rejection like anuria, fever, and Lyme pain. Sometimes if the patient receives biologics, sometimes of the biologics, the baby shouldn't use life attenuated vaccine for at least 6 months. Thank you, Ahmed.
Thank you.
Thank you. Dr. Aisha, are you with us?
Oh, yes, sir.
Okay, good.